And then we're going to use the Q&A, right?
Yep.
Okay.
So you're welcome to start.
All right. Well, welcome everyone. I'm Jason Cook. I'm one of the vascular surgeons at University of Nebraska. Oh, Angela, do you mind sharing that slide again? It disappeared.
No, I know I shut it off so we could start, but I'll put it back up.
Oh, perfect. So I'm one of the vascular surgeons at University of Nebraska, and I am getting to spend a year as the chair of our medical student society's committee. And so we try to do a couple things throughout the year. And so when Angela pulls it up, we'll talk about what we've done. But we got to run an earlier webinar on different types of vascular surgery and infectious complications. Today is really just an overview of what is vascular surgery, and every year we try to take a different way to attack this. And so today we'll get a talk on what is vascular surgery and how to make an impression on a vascular surgery rotation. And then we'll finish with, I think, what's going to be kind of fun, which is the student and faculty version of what is the vascular surgery pathway that's right for them and how to get a good mentor. And the goal of this is we want you guys to communicate with us, to talk to us, to ask questions, use the Q&A throughout the system, and we'll get to respond. And please enjoy. Lastly, and but not least, Friday, September 18th, obviously Midwestern Vasculars meeting is happening in Chicago, so there's no excuse not to come. It's easy for everyone to get to. We're gonna have a great simulation session where we'll get to do a bunch of on-table skills with a couple of the different companies, and hoping to have you guys out there. So with that, we're gonna start with Laura Healy, who's gonna talk about what is vascular surgery.
Hi, thanks very much. I am going to start sharing my slides. So I'm Laura Healy. I'm a vascular surgeon at SIU School of Medicine, and I have stolen some of these, slash all of these from Dr. Cook from last year. So I appreciate your contribution, and have edited them to look like my own. So thanks very much for being here. And here's a picture of some of our favorite operation, which is a carotid endarterectomy. So what is a vascular surgeon? So the kind of AI slash Google definition is a vascular surgeon has expertise in the diagnosis and management of patients with disorders of the arterial, venous, and lymphatic systems, excluding vessels of the brain. That goes to neurosurgery, and the heart, which obviously goes to CT surgery. Vascular surgeons have significant experience in providing comprehensive care to patients with all types of vascular disease, including diagnosis, medical treatment, and reconstructive vascular surgical and endovascular techniques. So one thing we'll talk about a couple of times, but I think is important to keep in mind is that vascular is super comprehensive, I think, in that we treat people with medicine. So we start people on aspirin, statin as needed, sometimes even GLP-1s if needed. And then also that we do both endovascular and open techniques. And so medical management, surgical management, and longitudinal care. So I think that's pretty unique and special about vascular surgery. So what do we treat? We treat the whole body. I sort of explain it to my mother as anything below the chin, except the heart, which I still don't think she understands, but we treat all arteries, all veins, throughout the entire body. So here is the different two incisions for a CEA, so a carotid endarterectomy versus a TCAR. So you can do things, kind of TCAR is a great example of sort of a hybrid approach where you have an open cut down on the carotid, but then use a stent. So endovascular and open at the same time. Great hybrid case. Here is the two examples of how to fix an aneurysm. So open versus endovascular with a stent on the right side. Here's a good CTO or occlusive lesion in the lower extremity and getting through it and stenting that open. Here is an extensive DVT causing phlegmasia, which is kind of our top concern when we're called from our residents and determining whether there is compromised blood flow to the foot because of a DVT. Diabetic foot ulcers and revascularization with a bypass on the bottom. Varicose veins, which is everybody's favorite thing to ask you about at parties. And then fistulas or aneurysmal versions of them as well. This is an axe fem on bilaterally, so redirecting blood flow whenever there's any occlusion. And then we do thoracic outlet syndrome, which is very common among repetitive sport athletes. And here's a first rib resection for that disease process. So ultimately, we are increasing in need in all centers. And the reason for that is because when people get into trouble, we're often the people that they call. So this is one paper on the left showing that consultations have increased over the last kind of 10 years from 2002 or 15 years from 2002 to 2017. Um, and that is kind of from all specialties. And then on the right hand is when vascular surgery is called into the operating room. And over the last 9 years, 430 cases where vascular was needed, 131 of them being urgent or emergent, and 22% of those being hemorrhage control. So you will get called from OB/GYN, you will get called from neurosurgery, all sorts of, interventional cardiology, interventional neurology. So all sorts of specialties will call us to try to help in the operating room when things go wrong. Vascular surgery is often the person that is called. So they call us sometimes the firefighters off the operating room. And that's one of the things that I think is really appealing is that I think we're kind of the pinnacle of excellence in terms of who you would try to ask for help. So surgeons often ask each other for help and in difficult situations. And the vascular surgeon is sort of the last person that you call. And I like that about us. So it gives you lots of job security as well. The nice thing about vascular is also that it's diverse in its locations and what kind of specialty you want to create for yourself. So you can be in the clinic, you can do kind of vein work, you can do outpatient clinic procedures like on the top, you can do open surgery, you can do endo surgery, and depending on where you train, you might be heavy in one versus the other. There's private practice, there's academics, so there's a wide variety of kinds of vascular surgeons that you can be. Carotid disease is one of the main things we treat. So this is showing you the sternocleidomastoid and the incision that will be made, opening up of the common and the internal carotid in order to do the endarterectomy. So some nice anatomy, some good bread and butter case there. First done in 1965, and then 1980 stenting came about, and now we sort of have what we call, the TCAR, this hybrid where we take blood flow and shunt it to the vein through a filter so that all of the debris during the procedure doesn't go to the brain, much lower risk of stroke, but is also a stenting technique. But also you don't go through the arch, so you reduce the stroke risk there too. So lots of new technology. I think vascular surgery is really good at adapting new technology and studying it pretty thoroughly. So that's another thing I think is appealing about the specialty is that kind of constantly changing and very self-reflective. Abdominal aortic aneurysms is another fun bread and butter situation. These are the types of aneurysms we treat. Lots of infrarenal cases, but patients are getting more complicated and becoming, higher and higher up in previous stenting. So it's definitely requiring us to adjust our practice as we go with older population and previous fixing before. So again, two ways to fix it. Open is you sew with a graft like on the left, and on the right hand side is a kind of fenestrated complex endovascular repair. You see the renal stents in there. Thoracoabdominal aortic aneurysms as well. So here's an open graft on the left that you can see, and all those, that's the positioning for the patient. So thoracos are kind of our coup de grace, if you will. Then there's peripheral arterial disease, which is a lot of patients as well. Also makes up some of our bread and butter stuff. So you'll see all the disease present on the angiogram in A, and then the B is showing a balloon angioplastying. So you get a wire across it, then a balloon. Then and D are kind of or C is more ballooning, and then D is your end result. So you've improved the trifurcation, the popliteal below the knee, and then ultimately your outflow as well is the goal. Then again, there's always the, tried and true bypass if needed, which is on the left-hand side. You got your Wheatie in there and you're, grabbing the vein and trying to bypass your occlusions. So, what actually is vascular surgery according to us? The specialty for the treatment of arterial and venous disease, including medical management, minimally invasive, endovascular, open, hybrid approaches. And it's a surgical subspecialty that supports other surgeons and interventionalists throughout the hospital. You develop long-term relationships with patients because you're following them for the rest of their life. Anybody who has atherosclerotic disease in one vascular bed is bound to have them throughout their body. So you might treat this person for a carotid, and then the next year they come back and all of a sudden they have life-limiting claudication that you had been following, but been trying to treat medically and now has reached a pinnacle where they can't actually live their life. So these are full body visits that you have with them annually, and also you take care of them for the rest of their life because atherosclerosis doesn't go away. So they will continue to have problems in these arterial beds for the rest of their life. So it's very rewarding, super needed, and always, as we said, job security, but very, very great technically, super fun, and always staying on the edge of technology. So I'll stop there. I think Dr. Alizad Dagan, sorry, is next, if I'm not mistaken.
Yeah, Angela, who do we have on next? Was it Zach?
Zach, it's just
Yeah. Zach, can you share yours?
Yeah, my next. I'm happy to go.
Yep.
All right, is that coming up for everybody? I'll take that as a
Yes.
yes.
Yep. Looks
Yeah,
good.
Yes.
perfect. Thanks for the opportunity to talk to everybody this evening. My charge was to be part of this as an introduction to vascular surgery, to look at the faculty perspective. These are my disclosures, and specifically these topics about how to make an impression with vascular faculty, vascular trainees throughout all your interactions, not just on rotations, but outside of rotations, as well as which pathway is right. And we basically have two training paradigms between the integrated vascular residency and the fellowship pathway. So for the first one, I'm going to talk about a little bit about, is vascular surgery a specialty I'm interested in? So Dr. Healy pointed out a number of the different operations that we do, and the things that we do are quite different from what other surgeons do. So are you interested in the specialty and the operations that we do? And are you interested in the longitudinal patient care that we have? How do you go about finding mentors? And that extends all the way from finding mentors within medical school that maybe a couple years ahead of you to finding faculty mentors and long-term career mentors. What are the things that you need to do to excel on clinical rotations? What do we look at as faculty? How do you navigate some of the aspects of the application process, whether it's a sub-internship after your core clerkship rotations, getting letters of recommendation, and then ultimately the interview process. And then, as I said, we'll talk about the different pathways, which one might be right for you. between going into the integrated vascular surgery residency right out of medical school versus potentially general surgery training and a vascular fellowship. So, my biggest piece of advice as far as finding if you're interested in vascular surgery is doing exactly what you're doing and being part of this webinar. So explore the specialty early. Find out if your school has a vascular surgery interest group, and if they don't, start one. Get involved with the general surgery interest group, and have vascular sessions with that. Participate in student groups through other societies. Talk to the students that are ahead of you, planning to match into vascular surgeries, MS3s and MS4s that may be further along in the process. Attend vascular conferences at your institution. So that can be M&M conference or educational conferences, grand rounds, things like that. As I said, opportunities through this society and other societies that run student programs as part of meetings, as well as longitudinal programs as well. And ask yourself a few questions. Do you enjoy the vascular anatomy and physiology? Are you interested in having longitudinal patient relationships, which is different than many other types of surgery? And are you excited by both open surgical techniques as well as endovascular procedures? And really, do you like solving complex clinical problems? As Dr. Healy pointed out, there's usually several different ways that we could solve any particular clinical problem that we're dealing with a patient, and coming up with the right solution is part of the fun part about the job. So getting into mentorship, I encourage you to think of mentorship as a team rather than a particular individual, and think about it all the way along the lines. So as a new medical student, you can look at the MS3s and MS4s. That can help between a core clerkship student and a sub-intern, a lot of learning there and some mentorship there as well, onto being an intern, a junior resident, and then the chiefs or the fellows on any individual service that you're participating on, and then of course the faculty as well. Be consistently present. So again, at your own home institution, attend conference intermittently. Show up for your rotations, inquire about research, things like that. You don't need to be constantly present, but be consistently present. Volunteer for projects that interest you, get involved in research in your institutions. Follow through on any commitments that you make. So when you make a commitment, whether it's as simple as a meeting versus putting together data for a project or writing part of a paper, make sure you follow through on those commitments and hit deadlines. Stay curious and ask thoughtful questions throughout the process, and keep your mentors updated on your progress. Your mentors are going to be interested to know how you're doing, what you're doing, and how your thoughts change as you explore this as a specialty. Moving on here, how are you going to make an impact on clinical rotations? Number one is preparedness. So, before you show up for that first day, read about your patients, read about their pathology, read about the patients that you're going to be rounding on service. Review imaging and know the operative plan before a case. Touch base with the residents and look through the medical record for that patient. The day of, be engaged, be present in the operating room, ask thoughtful questions, discuss patients in clinic. Be helpful, help the team, help getting supplies for rounds, help with moving patients back and forth between their gurney and the OR table. And then afterwards, continue to follow your patients. Read about what you saw, seek feedback about your performance in the operating room if you did get a chance to suture or participate in the operation, and continue to read about your patients in their recovery process. So, and you can see that, those are the things that us as faculty notice: preparation, curiosity, coachability, reliability, and being helpful to the team, not just us as faculty, but to the entire team. Getting into the sub-I letters of recommendation interviews, this is a topic that could be its own talk totally. So I'll just briefly hit on these. So when you're on your sub-internship, make sure you function as an intern, make rounds with the team, jump into dressing changes, move patients, and be helpful. Accept feedback and show consistent improvement. Seek that feedback out. Once it's time for letters of recommendation, and when you're on that sub-I, target time and interaction with faculty you think you'll like a letter from. Meet with them early in their rotation, express interest. And then when it comes time to interview season, make sure that your application demonstrates that you're qualified, or I should say your application does demonstrate that you're qualified. That's why you got the interview. And the interview is really all about fit with the program, and you want to be authentic. And then quickly on training pathways, you guys probably know this stuff, but integrated vascular surgery is a match directly from medical school. It's 5 clinical years of training with a variable amount of research. Some programs have 1 year, some programs have 2 years, some programs have no years. There's at least 18 months of core rotation. Some programs have a few more. That's where you get your general surgery time. Versus the general surgery to vascular fellowship pathway, that's a match in the 4th year of medical school and a general surgery residency where you experience all the aspects of general surgery. And it's at least 7 years of clinical training, plus or minus that same research time. So 5 years of general surgery and 2 years of a vascular fellowship. And one thing with this paradigm is there can be variable vascular experience in residency. But I will emphasize that both paradigms train outstanding surgeons. So you may be interested in integrative vascular surgery if if you know this is the specialty for you, you're willing to commit early. You get broader exposure to vascular early in training. You can have earlier mentorship with vascular faculty. There were previously concerns about the open surgical exposure, but I think that's pretty much been debunked at this point in time. And that's evidenced by the ACGME requirement for non-vascular rotations, which has decreased over time. It is a competitive match. In general surgery, you get more time to explore different career options if you're not quite sure vascular is for you. You get broader exposure to general surgery. You definitely get more open surgical exposure, and it may be less competitive than vascular. So a few questions I wish students ask when they rotate with me is what makes somebody successful in this specialty? What do your happiest residents have in common? How can I improve during this rotation? What do I wish I'd known as a medical student? What qualities make an outstanding resident? And then 5 final pieces of advice here. Explore things early, explore multiple specialties, find mentors that challenge you, say yes to opportunities, focus on becoming an outstanding medical student, not just a vascular applicant, and ultimately choose a training pathway that fits you and your goals. And I always recommend students use this book to prepare for cases. It's a fantastic one. It's organized by operation, so it's nice when you get assigned an operation. So that's all I have for tonight. Thanks.
All right. Thank you very much, Zach. I think next we have Shannon. Yep. And Vasmi. So they're going to talk from the student perspective as residents.
Good evening, everyone. Thank you for the opportunity to present about which training pathway is right for me. My name is Vamsi Patle. I'm a 4th year integrated vascular resident at Loyola.
Hey, I'm Shannon. I'm a 3rd year vascular resident at The Ohio State. I went to Loyola for medical school, so I actually knew Vamsi during that time. And we're really excited to share with you the differences in the training pathways that we kind of alluded to earlier. Vamsi, do you have the slides?
Yeah, are they being shared or
They're
shared?
not currently.
Let me try sharing it again. 1 second. Can you see it now?
Yes.
Okay, perfect. Great. So the structure of our talk, we were going to start by talking about the 2 different types of training pathways. The main one is the integrated 0 to 5 program, and then the 5+2 fellowship program. And then we'll also talk about the opportunities for research, and then kind of talk about some key aspects of what can help you decide between doing a 0 to 5 program versus doing a 5+2 program. So the structure for an integrated program is you directly enter vascular surgery from residency, or from medical school. So you apply to a vascular residency. You typically do 5 years, 2 years if you're doing 2 additional years, maybe if you're doing some research. But your focus from the beginning is going to be vascular surgery, which is nice because you know what you want to do, and you're doing that from day one. The other benefit is you get more time on vascular surgery. The APDVS, which is kind of the Program Director Society, recently just approved improved, going down as low as 12 months of non-vascular rotation. So you'll have 48 months of vascular surgeries when you're a resident versus 24 months as a fellow. And then even when you're not on a vascular surgery rotation, the rotations that you're on are really focused at making you a vascular surgeon. So you'll do things that focus on working on vascular reconstructions or more open abdominal exposures. And it's really all tailored towards being a vascular surgeon. And so that means that you have less training time. So you can either finish your training earlier, but it also gives you more bandwidth and time to do additional fellowships. People have gone on to do things like cardiac surgery fellowships or complex aortic fellowships. So if you know you want to do vascular from the beginning, it's a great opportunity to really go all in on the field. One of the downsides, though, is you are kind of having to commit to the field as a medical student. And just as being a medical student, you're not going to have as much exposure necessarily or experience in trying to decide what you want out of your career. Whereas general surgery, you may have more experience to all the different types of surgical fields. And this potentially could, if you make the wrong decision, could end up choosing to quit or change specialties or just burn out. The other pathway is the independent pathway, and this is structured so that you do a general surgery residency and then you do a vascular surgery fellowship. So, as mentioned earlier, it's a longer training pathway because typically 5 to 7 years, depending if you do research or not, and then an additional 2 years for the vascular surgery fellowship. The benefit of it is you really get a broad exposure to the full breadth of surgery. So you'll get exposed to more different types of techniques. So typically, vascular fellows are more comfortable, at least at the beginning, with open abdominal surgery. And they also get exposed to other things like laparoscopic or robotic surgery. Robotic surgery, for example, is something that's potentially becoming something that can grow in the vascular field. So people who have done the general surgery route will have an easier learning curve to adopt that. You also get exposed to a broader breadth of patient populations. Typically, the vascular patient population is on the older side, but if you do general surgery, you're doing everything from the pediatric population up, so you'll have more variability in the patient populations you deal with. And also something interestingly is you'll probably have more experience with leadership experience, especially running a service because you've already been a chief before, which a vascular surgery resident may have some growing pains with that component. And then, as I mentioned earlier, you'll have more experience when you're actually choosing to do a vascular fellowship if it's a good fit for you. A couple of the downsides is you have less time to master the vascular surgery skill set. Vascular surgery is pretty unique in that we have a whole nother surgical set of tools of endovascular surgery that you don't really get exposed to much in general surgery. So that's a steep learning curve that you have to adapt to, and you have less time. But also, because you have less time to master the skill set, you might not pick up on nuances as much that you have to pick up as an attending. But of course, both of these pathways have been demonstrated to have equal level of competence, but it's just the different growing pains that you have to deal with.
Thanks, Vamsi. So getting into research differences between integrated and trained vascular surgeons. So you have the option to add essentially 1 to 3 years of dedicated research or academic development time in either training program, I would say. So for integrated, when you look at a lot of different programs, there's programs that have mandatory 2 research years, there's programs that have no options to do research, and then there's programs that are optional. So the program I'm at is optional research, so we will make time for you if that's something you would like to do, and we'll compensate and figure out how you're going to get funding and how we'll change the call pool, things like that. And so I think a program that if you know you want to do, like have your own research lab, maybe try to get a PhD during that time, so take 3 years, you probably need to be at a center that already has that built in and that will be able to support you for that. But in general, people who do the fellowship training program, they do their 2 research years in the middle of their general surgery training. And so they still have that background that can help them become an academic surgeon, help them set up a lab. Mostly traditionally they were doing this to become a more competitive fellowship applicant as well. So I think, in medical school, you have to be really involved in research, and this shows interest in the field and will help you on your residency applications. But you need to take time to reflect for yourself too, how interested you are, what type of surgeon you want to be in the end. And I think this also can help you make the decision if the general surgery training pathway, then vascular fellowship is right for you, or if it's the integrated pathway. So in terms of which one is better, I think it depends on you and what you're looking for. Like I said, in terms of research, when you want to do it, if you want to do it at all, what type of surgeon you want to be overall, and kind of the type of learner and person you are, how much time you think you need to learn certain skills, how much time you need to learn leadership skills, running a team, those types of things. I think it's good to self-reflect on that. But either way, as Vamsi mentioned, other physicians have mentioned on this panel, both pathways have been shown to train safe and competent vascular surgeons. So these are actually two studies involving Dr. Smith that looked at integrated trained versus fellowship trained vascular surgeons. So the first one looked at outcomes for carotids, aortic aneurysms, open and endo, and lower extremity revascularization. And then the second study looked at assessments by trainees and attending and their competency and autonomy. And essentially both studies found that there were no differences. So I think it's really a personal decision, and you really need to talk to your mentors in both vascular surgery and figure out which one training has shown that studies have shown that the training is equal. And I think a lot of this depends on where you choose to train as well. So getting really good mentorship when the time comes to decide is really important. So in conclusion, the integrated pathway, you'll have more vascular focus, and it's best if you for sure want to do vascular surgery, you had a lot of exposure, and you feel pretty confident in your decision. The independent pathway, 5+2, so you have more options. You can always switch to a different specialty later on in your general surgery residency. But either way, find the right mentors and you'll find the right pathway for yourself.
All right, thank you very much. So I think that's very true. I think both pathways work. Some people like to make the decision earlier. Some like to see a little bit of everything. I think, in the current era, vascular surgeons are not doing a whole bunch of general surgery. And so there is some utility of going straight through. So last we have Sharia, who's going to talk about how to find a mentor and get what you need from them.
Share. Can you see my screen?
Yep, looks great.
All right. Hi, my name is Shahriar Elizadagan. I'm a vascular surgeon at Medical College of Wisconsin, and just wanted to thank you for my opportunity to present my topic. I do not have any disclosures to make. This talk is about mentorship, and just briefly explain about mentors and then their qualities and what to expect and what to do when you find a mentor. Basically, mentor is an experienced and trusted person who guides, advises, and supports someone with less experience. Some other words that are used interchangeably with mentor is guide, coach, advisor, and teacher or role model, but the mentor could function at any of these. And the relationship between the mentor and mentee is different in a way that is a two-way road. They basically get feedback to each other, but for example, a coach or an advisor, it might be only one-way relationship where the coach just guides the team and tells them what to do to score better. What are the qualities of a good mentor? First and foremost, a mentor has your best interests at heart. It means that it does and it does and decides and advises you in the best way that you will have the benefit. And he or she really enjoys and gets rewards in helping you and helping a younger person who is pursuing his career or his dream. Some of the mentors could be warm and fuzzy, really easily approachable, and they always make you feel good. That's great. Or sometimes they are tough and they always ask you for more, and you feel that they are not satisfied. That's not a bad thing. That may mean that they think that you have greater potential and you can push yourself more and do better. Good mentors are accessible and can give you some time. You can meet them, you can approach them. They are knowledgeable, enthusiastic about what they do, and they are nurturing. They are either senior colleagues, your faculty you're attending, who are supporting you and helping you to grow and flourish. But what do the best mentors do? They recognize the importance of underlying relationships. So the most important thing is the relationship that you build with your mentor, and everything is built based on that. They help their mentees to develop character rather than competency. Like competencies like surgical skills, technical skills, or knowledge are very important, but a great mentor will help you to develop character, how to react, how to interact with people, how to interact with your environment. And that is very important. They focus on values and self-awareness, and as I mentioned, over technical skills or knowledge base. They will encourage you to explore and always look for more knowledge and more answers to their questions, better answers to your questions. And before they criticize you, they will consider any reason or all the reasons that your idea might be better than theirs. They value their mentees above their organization, meaning that you are the most important person in this relationship. It's not your organization, it's not your hospital or division. And also, they will help you to discover your passions and avoid steering them according to anyone else's ideas or agenda. Let's say that your division chief doesn't like your idea, or you disagrees with what you think, but your mentor will do the right thing and gives you the will give you the best advice. Who could be your mentor? Well, there are different levels into it. I mean, if you are an M1 and M2, your upperclassmen, like M3s, M4s, could be a great mentors for medical students because they can provide you insight into your attending, your professors, your exams, and the flow in the medical school. And then also your residents, if you're in surgery specialty, surgical residents can be a great source because they can give you insight into a specialty and real workflow and expectations, and also guide you through residency. And you can get real-time clinical teaching from them. And then finally, faculty can give you long-term career advice. I mean, you can have your mentor who is a faculty can be your mentor, and then after 5-10 years could be your colleague, or your basically you can function as in the same team. And they can give you deep expertise in the field because they've been there before. Also, they can offer you letters of recommendations whenever you need it. And also they can introduce you to other faculties, or explore other opportunities for you to grow or connect with other people who can help you be your mentor. Now, where to find a mentor? I mean, you can find them anywhere, but the closest and easiest place is your clinical rotations and your hospital. that you can approach any attending or anyone who think that you like their style, or you think that they're approachable and they have some interest in the specialty or the subject that you are interested in. Or you can, when you attend your local or regional or national meetings, you can simply approach people who you think they could be good mentors for you. And these are really good opportunities for you to approach. But don't forget, you need to approach. Without approaching your faculty or your potential mentors, you cannot find out if they're going to be your mentor or not. You can volunteer or shadow and ask them, just can I shadow you during your rotation or in your clinic, or volunteer to do something, and that will not be on notice, and they will understand that you have interest, and then from there you can grow, and you can grow the relationship and ask them for more things to do, and ask them if they have time to be your mentor. There are some structured mentoring programs in medical schools. I know we have it in Medical College of Wisconsin. I'm pretty sure other medical schools have them too. And but I think the relationship that you build yourself with a mentor, I think it's basically you will get more out of it. Not necessarily all the time, but I think if you approach, then you can keep that relationship for longer. Also, you can ask for research opportunities if they are doing writing a paper or doing research. If you can contribute to that, that is great, and that may open the door for you to get a good mentor. Don't miss any opportunities anytime. Your mentor, first, as I mentioned before, they should be approachable, knowledgeable, and successful, and enjoy what they're doing. You don't want to be someone, your mentor, who is always tired and complains about what he had to do in the OR and the long hours. No, you have to have a cheerful and successful and happy mentor. And does it? I believe that it doesn't matter that your mentor initially should be your own specialty. If I would tell you that probably it's better to get a mentor in surgical specialty, but because this is mentorship is not about your technical skill. It's something, it's a guide, and it's a help during your career and tell you what is right to do. And those patterns are almost the same in the career of a physician, even if they are not surgeons. And find out if you have any common interests outside the hospital that might be another way to open the door for you to communicate with your potential mentors. If they are doing mission trips, if they have you have common experiences, if you are speaking another language that you are speaking, and that might you may have the same interest. And now that you found someone to be your mentor, you found someone that you would like to be your mentor, how do you approach them? I believe that a simple approach is the best. You just go first, not without any knowledge. Try to know the person, know their interests, what they're working at, and then ask if you can schedule a time to speak with them in person and explain something that interests you, speak something about yourself and your goals, and ask if they be willing to help you. And also ask them if what is their expectation. Some of them will say that, well, if you want me to be a mentor, I want you to work on this research. We will have to meet like every other week, and exactly know what their expectations are. And if you made that relationship, you promise them that let's say every Friday evening you're going to meet with them, do what you say, be on time, where and when you're going to meet them. and always keep them informed. Let's say that your mentor introduces you to another surgical specialist about the research, and you need to keep them informed that, okay, what happened during this meeting. They update them and tell them that, well, this was what we got from this meeting. So never forget to follow up. If you ask them for mentorship, they didn't respond, you need to follow up and show your interest. And with your mentor, always try to ask intelligent questions. Don't overdo it, but show them that you know what you're talking about and you have studied and you have done your homework. Always ask for feedback, and when you get a letter or any recommendation or introductions, always thank you, and or always thanks them. And I think that this is all what I have for you.
Thank you for that. I think it's really important to remember, they don't have to be in the specialty you want to pursue. I think it's somewhat helpful when you're thinking about where to apply and so forth to have a mentor in the specialty. But a surgical mentor is a surgical mentor, and there are a lot of things that they can help with outside of the specialty that may or may not be your long-term interest. But I also would echo the importance of really saying what you're also interested in. I think one of the hard parts for us as faculty, right, is we have a lot of students who come up and they say they want a mentor, but we also don't always know what they want in that relationship. And so I'm happy to be a mentor, but are you interested in lifestyle questions, how to apply, how to get engaged? And if you approach it with a much more confident, approach of saying, hey, I'm interested in having a mentor to talk about, the different aspects of training and stresses, et cetera, it makes it a little bit easier for me to say yes, as opposed to I would just like someone in vascular surgery who's a mentor, right? That's a much more open-ended relationship. And so, one of the best parts for tonight is everyone stayed on time, and I want to thank everybody for their presentations. I was finishing up a case, so I was sort of back and forth, but the vascular surgery is really a really broad field, and so it covers so many different things. You can make of it whatever you want. If you want to be a complex aortic surgeon or a dialysis surgeon or a vein surgeon, and that can change over the course of your career too. As you may want to change your hours and stresses. But I would like to save a couple minutes for questions. So if anyone has questions, please don't hesitate to use the Q&A system. So far, we haven't gotten too much. I don't know if there's anything anyone else would like to add if we have a few minutes while people are waiting to give us some questions.
Yeah, nothing more than what I really said, Jason, but I think just being curious and showing up and being engaged is the biggest thing that you can do, no matter what specialty you're interested in.
I think that's also true, for especially the interaction with faculty, but also with the residents, right? I mean, a lot of us will hear from our fellows and our chief residents, that so-and-so was not a great, student. They weren't well prepared for rounds. And, sometimes we're surprised, right? Because you say, hey, they were great. Every time they came to my clinic, their FaceTime with me looked great. But not always with the other trainees, right? And remember, it's a team sport. Everyone's involved and everyone has a say at the end of the day with how people perform.
And that goes for everybody too, the staff in the clinic, the nurses in the operating room, everybody that you deal with throughout a rotation.
Yeah, totally agree. I mean, I think for all of us, right, our ability to function on a daily basis is not just the students, the trainees, right? It's your nurses, your providers, your nurse practitioners, your PAs, as well as your OR team, right? Our ability to get multiple cases on a day, including flipping rooms. And so anything you can do to get a good reward with those guys too goes a long way.
Looks like we have 2 questions if you guys want to jump in.
Yeah, so why don't we start with how much research does one need? I think there's a wide spectrum. I did a PhD in med school. I have an MD PhD. That is by far not the expectation. And it's also hard, depending on the program, whether that program wants people who do research. I think it's a good thing to leverage your vascular mentor to know what sort of the expectation is for the different programs. I would say having, a paper or two at least, and those can be case reports, just demonstrating interest in the field. One of the hard parts of vascular surgery, if there's one resident per year or two residents per year, programs are taking a bit of a gamble on you as well. And they want something that demonstrates that you know what you're getting into. And some of that is the face time of getting research, done and knowing what you're doing. Do you guys have additional insight?
Yeah, I'd echo that. I think that, it is the specialty is becoming more and more competitive. That is for sure true. But what I look for in an applicant is sort of a trajectory where you're showing interest in, I can see your path of interest. We have plenty of trainees who have done research in other specialties before they come to vascular, and you're learning skill sets and you're learning research techniques that then you apply to vascular once you get exposure clinically. So I wouldn't say that you necessarily need to have a great breadth of vascular research, but what I want to see is that over the course of your time in medical school, you've pursued things, that you've showed interest in things, that you've created value on, being a team player through research projects and seeking out mentors and learning skills. And then when we sit down for the interview, you can tell me, yeah, I did this project, I learned this skill set, I came to vascular at this point in time, and this is how I'd like to apply that moving forward.
Do you guys have advice on someone who's thinking of doing vascular at the last minute?
I
Attend
think
a
that
meeting.
what's that?
I said attend a meeting. MVSS.
Yeah. And I think also have a mentor at your home institution that can make some phone calls and say, this person is can't miss. They came to the specialty late, but they're super interested and it's genuine. It's not something that, is fishy on the application.
But I think it's also important to be open and transparent on the application, right? We get a lot of applications and we can tell, where people's heart really is, right? And if someone sees that you don't have a bunch of vascular research and, you don't have a bunch of vascular surgery letters, they're going to have questions, right? And you can be open in your personal statement about how found the light at the end, and want to do vascular for all the following reasons and take that concern off the table, right? You may not have the research in vascular surgery, but if you have the research, that will absolutely help. And then the question on the how do people view research? I mean, I would say no one besides my old program director from WashU would say they view research as unfavorable, though Jeff Jim love to give us a hard time. But I think people who come from a background of research, overall are very competitive. And so taking extra time is not a bad thing. It makes you a more mature applicant. I think people tend to interview better after they've had more time under their belt in medical school. Does someone want to tackle the question about the nervous system? I would say the carotids are, the skull base is sort of the end of our territory. You can do combined cases with neurosurgery to get into the skull. Occasionally you'll get called to like ENT cases where they're doing a large tumor resection and you need to oversew the internal at the skull base. When it comes to other types of nerve type work, I think that's where you get into the order of the what's the new device for the barostimulators and so forth, where you can place these patches on the carotid to alter the carotid body. Obviously, doing thoracic outlet work, you do a lot of neurolysis and working on the brachial plexus. But there aren't really advanced fellowships for nerve type surgeries. And obviously carpal tunnel and cubital tunnel release, all of that is, really in the spectrum of plastics and hand surgery
I would
and
say
orthopedics.
one thing, there's a lot of it's more management of neurological complications, and especially in complex aortic surgery. We do a lot of research work around the management of spinal cord ischemia, prevention, monitoring, treatment after the fact, and that's been a pretty robust area of research. But again, not treatment directly.
I would say in terms of the types of research, it's both, case series, local case series, or DQI work. In terms of what the medical students have done, but getting an interesting paper here and there just demonstrates that you have an interaction and a mentor that you talk to, and it demonstrates your interest in vascular surgery. Just reading this one about working with more rural populations and wanting to go into vascular surgery, we'd like to pursue an integrated program. I think that this is an interesting question, so let's toss it to the group and see.
Yeah, vascular surgery is projected to be the most in-demand specialty over the course of the next 20 years or so. So I don't think that you're going to have any trouble doing plenty of vascular surgery as a full career, almost no matter where you want to be. So I would do it based on interest. If you're interested in doing some appendectomies, some cholecystectomies, and you want to have the addition of a general surgery practice, you could consider it, but I don't think it's necessary.
I believe that, I'm working in a rural area and I'm the only vascular surgeon there. And I think my general surgery training helps me a lot. For example, let's say if I have a ruptured aorta, ischemic colon, I need to do a colostomy or take it down. I don't call general surgery for that. And because I own the patient as general surgeon, you do everything you need. And let's say if I end up with a hernia after open aortic surgery, I fix it myself. Is it a good thing? I like it. I don't know. If surgeon could be different. You might, if you want to do only vascular surgery, you just do your thing and you leave the rest of it for general surgery. Because I love both of them. I love general surgery, but I don't do general surgery. I just do it for my own patients if they need to. It's rare.
I do think it would make you more marketable, whether it's something you're interested in or not. I think should drive the question. I agree with Dr. Rankin. I think you'll get a job regardless. But I do think if you're more widely trained in a 5+2, that you have more things to offer a general surgery hospital in the same way that, an OB rotation is helpful to a general surgery resident who is looking to have a rural practice. So, if you're truly looking to be a rural surgeon, then I do think a 5+2 is helpful to your community.
Mhm.
Yeah, I agree with all of that. I think there's definitely opportunities for people that are 5+2, especially in the rural setting. Um, Transitioning from that to the next question is, what about the 0 and 5 and then going into a CT fellowship? I mean, there are people that do these sort of super aortic fellowships who want to do everything from CABGs to thoracoabdominals to PAD. I think the problem in the vascular space is the average vascular surgeon is so busy already. You're not going to be a jack of all trades doing everything. I think if your interest is as a complex aortic surgeon and you want to do it that way, there are opportunities. I don't know people that do a true CT fellowship after an 0 and 5, but I don't see why you couldn't. It may not be an ACGME.
Two of the graduates from the program I trained in went into CT afterwards, and they're both doing cardiac surgery. They're not really doing vascular surgery. I mean, I think, some people ask that question from the standpoint of what you brought up to start with, of being an aortic surgeon, basically from the valve to the bifurcation. And I think that the opportunities to use that full skill set and have that be the core of what you do are pretty rare. So I think those people tend to just do mostly cardiac surgery.
Yeah, we have a couple people at Loyola who have or are doing cardiac fellowships. And typically those are people who are interested in complex aortic work. But if you want to do, there are some private practice surgeons. We get a lot of referrals as well where they've done from cardiac surgeons, but they have people in their practice that have recently joined that do full spectrum of vascular surgery. I think if you want to do everything cardiac and true cardiovascular surgery, you have to do it in a private practice setting. It's kind of difficult to get all those opportunities in an academic setting from the cardiac vascular trained surgeons that I've talked to, at least. So it depends on what you're interested in.
Agreed. And I think, to the last point, what about like an external rotation for applicants? I did one as an integrated applicant. I think it's really helpful. Vascular surgery is so different depending on where you are and what you see. Um, is it required? No, but the vascular world is a small world. And so it's definitely helps you. It's nice to have a letter from another institution saying how wonderful you are, and so it's not you're just your home institution. I would say if you do not have a vascular program and you want to do integrated, it is really really helpful to get that integrated program director's letter saying I want so and so in my program. Right, that is what we look for, even in the vascular fellowship space for 5+2s. Right, the best letter we get is a different 5+2 program director saying this applicant is outstanding and I want them in my program. Do one of you guys want to tackle the resources?
I'm a little far out from the M3 resources, unfortunately, so I don't really know what the latest stuff is. But in terms of vascular, I think the Gore Combat Manual is probably the best quick and dirty book to read. That's what I use, and it never failed me. Um, I don't know if things have changed, but for general resources, I always use Reddit and kind of picked 3 or 4 different resources and then narrowed it down to 1 or 2. I think UWorld and Amboss are probably the 2 gold standard like question banks that you should use, and then supplement it with one like good reading resources would be my recommendation. Third year is a little different than your first 2 years in that you are not going to have the time you had to use all these different resources or sit around. You're going to be in the clinic, so you really want to tailor down the resources that you use and focus on just 1 or 2 things. And practice questions have consistently been proven the best way to perform on tests. So that's what I would recommend starting with.
I'll reiterate the resource that I showed in my talk too. That's the Elliot Chaikoff Atlas of Vascular Surgery and Endovascular Therapy. You can generally get it on Clinical Key, which is usually available through your library at your medical school. So most people have access to it electronically. The nice thing is it's organized by surgery. So let's say you're assigned an above knee amputation tomorrow, you can read that chapter and be prepared for that individual operation. And it kind of works backwards from the operation to the pathology and the physiology and the considerations. And then the other one that I would say is that the Houston Methodist DeBakey YouTube channel has great videos for operations.
Yeah, and I would say the only other one that we routinely push is Anatomic Exposures in Vascular Surgery by Valentine. That's another, it really lays out the anatomy, helps you answer those nice questions that you're going to get asked about what is this and what am I looking for? And definitely something that you should be able to grab through your local library if the vascular guys don't already have a copy that they lend out. And then data on charting outcomes showed importance of AOA being matched and unmatched. I was wondering, what are your opinions? I guess that's specifically for the integrated vascular. Obviously being an AOA does make you more competitive, depending on how the groups are ranking people. But the idea is to get your foot in the door and then make an excellent impression. The rest of it is not necessarily makes or breaks people. And so being at an AOA program or at a program where you don't have AOA does put you at somewhat of a disadvantage depending on how people are sorting applications. I can say as a program that does not have an integrated program that doesn't have to worry about this. So obviously this does affect us from a general surgery standpoint as well.
I mean, I think it's always good to have something that boosts your application. I wouldn't use that as a deterrent not to apply to vascular. I know people who have matched with low board scores, not a lot of research, or different things that you can always consider as a weakness in an application. I think the goal should be to try to overcome that weakness and find ways to demonstrate that you're going to be a good resident and eventually a good surgeon.
And I also think if you know where the weaknesses are in your application, right, call them and try to leverage the strong sides, right? You don't want someone leaving a review of your application worried about the weaknesses, right? And you know the things they're going to look for. They're going to look for publications. They're going to look for a track record of vascular surgery. They're going to look for your honors in surgery, right? And any of the red flags, and just be open and use your personal statement to help leverage why you should be someone that the program is interested in and what makes you better than the other people that they're interviewing. But I would say once you interview at a place, it's less important, right? Those are the things that people are using to get you in the door, just to sort through, 100 applications. Once you're in the door, vascular surgery is a small world. We want to make sure that the person we're training is someone that we can, sit next to for 5 years at least, and someone that we think is going to complete the program. All right. Any last minute questions? I want to respect everybody's time and give people an opportunity here. One of the things with MVSS, is we try to have a great society that's interested in education. So again, please come to Chicago, come and interact, come and see us, come to the simulation course. We always have tons of people come, and I think everyone has a lot of fun getting to do some things hands-on with the different simulators, both open and endovascular. And if you have questions, feel free to reach out. Our information is online. And please, identify a mentor, identify someone you can start the process with. If you're interested, and even if you're not sure, still at least gain some insight by reaching out and chatting with one of us. The vascular is a really fun lifestyle, fun program, and you get to do tons of different things, which makes it really rewarding. And I think unlike the vast majority of surgery, right, these are your long-term patients. Clinic is actually kind of fun. You get to see these people for years and years and years. And you get to really try to help them through and improve their quality of life. So with that, it looks like we don't have anything else. So I just thank our speakers for giving their presentations, and thank you guys all for attending. Everyone have a great night.
Thank you.